Welcome to GTI and GTI Academy. This is module 1.1 of the emergency medicine series that we have actually online. And welcome to you guys on the video podcast as well as the podcast as well too, just for audio. If you are registered for a course in the Emergency Procedures Cadaver Lab, of course, this is one of the modules we'll cover. We highly encourage you to do these modules prior to coming. Today's module is going to be intubation, and we'll get right to it. Of course, with every module, we want to talk about the objectives, and this is part of the intubation series that we talk about. And of course, every time we have a CED event, we have to have objectives, of course. So this is what we'll cover. We'll talk about discussion, of course, of the anatomy of the airway. We'll also talk about indications primarily just for oral tracheal intubation. There'll be other airway management courses and modules as we move along, but today we're just going to talk about the oral tracheal intubation. We'll also identify the use of the particular equipment. If you'll remember, there's a few different laryngoscope blades, and we'll talk about what's valuable for those and then what's not. Also, we'll discuss rapid sequence induction medications, particularly for advanced practice providers. Some aren't very comfortable with some of the medications that we use, so we'll take a deep dive in that as well too. Also, we'll talk about techniques and assessment, and then finally we'll talk about aftercare. One of the things that are I'm so passionate about. Everyone gets really excited about the idea that we're going to get to intubate and the skill of intubation. However, what do you do after you intubate the patient? This is ventilatory management, using a ventilator, obtaining ABGs and managing. So I certainly want us to talk about that too, because that's a full scope of what we do with the patients. It's not just the skill and you walk away. So I want you guys to be very proficient at that, and that's really kind of one of the goals that we want you to have for this course. Here at GTI, we use kind of a unique way of teaching and guiding you, and one of those things is that we want you to do all the pre-testing before you get here for those that actually come to the labs. If you don't come to the labs, of course, the pre-tests are important as well too. We're going to teach you the basics of whatever topic it is. Obviously, you're going to observe the skill, and then we have some evaluation and testing following that. We feel like this is a really great way for the adult learner, particularly in the kinetic skills like intubation. So these are some of the things we'll talk about. Okay, so let's go to section 1. Obviously, we're going to get to just the introduction. So the basic principles include airway. So the airway is always the first and most critical action of the emergency provider. Now, we all know this because everything is A, B, C. There's CPR, airway, breathing, circulation. But particularly in the emergency setting, so not just in the ER or ED, we want to talk about maybe on the floor when someone has an emergent a rapid response and they have to be intubated. Someone in the ICU who is not intubated but needs to be. The airway is the most important. So security, there is no other action that should take place until the airway is secure. Just because you intubate them doesn't mean you move to the next thing. We want to make sure that the airway is secure. The third is control. So endotracheal intubation provides the most definitive control. We will talk a little bit about cricothyrotomy. That's another module. Nasotracheal intubation is some things that we want to discuss, but primarily the definitive control is endotracheal intubation. And then lastly, the most common. What's the most common procedure or skill that we use to intubate? It's always oral. Oral endotracheal intubation is actually the most common. You may see that on exam, but you want to use that actually in your clinical practice as well too, because that's going to be your go-to. So let's talk about choosing your method. How are you going to choose what equipment to use, but also when to do it? So let's talk about this. So number one, evidence-based. So we researched, and there's actually no evidence-based method established for intubation of choice. Now, what I've learned as a provider is it kind of depends on who I work with. So I work with some very seasoned physicians, and each of them has their own style, but there is actually no evidence base to support either way. So that's something to think about as well too. Next, experience. So the more experienced you are, the more likely you are to succeed. And so the choice of method and equipment is really dictated by your preference and the experience you have. I highly encourage you, early on to really focus on oral endotracheal intubation. And as you get really proficient at that, you can move on to the other, but you really have to do lots of these intubations. We'll talk about some research about when do you know you're proficient. Does it take 5, 6, 7, 8, 9, 50 intubations? Actually, the research does show that it doesn't take that many. It's really more like a 5 to 8. But obviously, the more you do, the more proficient you're going to get. Equipment. So available equipment at the facility in addition to the patient condition. Many of you may work in rural settings where you don't have a lot of support, and you may not have all the fancy equipment, bronchoscopy, cricothyrotomy, the access to anesthesia, and a lot of other skills like in the big populated level 1 trauma centers may. So you're really dependent on the facility where you work and also the condition of the patient. So that's something to think about as well too. So airway. So airway needs to be secure and controlled. If the airway is not secure, then nothing can help the patient, obviously. We'll talk about bleeding and the trauma, but you have to get an airway, you have to oxygenate, and you have to ventilate these patients before you can do anything else, regardless of what the medical condition is. So action. So the objectives are all actions aimed at these two objectives. They are place endotracheal tube rapidly, and number 2, the endotracheal tube has to be placed correctly. Now remember, for oxygenation and ventilation, when both are threatened, there are no good alternatives to intubation. So we'll talk about these concepts, but remember, oxygenation and ventilation are two different things. But if they're both threatened, you're going to have to intubate, and that's what we want you guys to be very proficient at. So let's talk about the anatomy. We're in section 2, and actually we're in the objective 1, which is the anatomy. So if you'll look at the slide, for those of you who are reviewing the slide, we're going to look at lateral and cephalic views of the airway. I guess the most important things to look at are actually the vallecula. If you'll see that, it's the base of the tongue, and this little protrusion is the epiglottis, and we all know the epiglottis is going to cover the airway when you swallow. Notice that the esophagus is posterior on this lateral view, and then the cephalic views, this is the operator view. This is the right image, as you can see here. Usually one of the most important anatomical markers is the uvula. So if you'll see that, for those who are looking at the screen, the uvula actually should be midline. Remember, the gravity of the airway is going to pull the tongue down. It's going to occlude this. And this is beautiful pictures. And I will tell you that these illustrations do not look like the real thing. Obviously, if you've intubated before, it just simply does not look like that. So you're going to have a lot of swelling. If it's a trauma patient, your patient may be obese. I don't know, but it's not going to look like this. You're going to have to do tons of these to become proficient at becoming the airway. So this operator view on the right-hand side, the uvula is really the most important. And notice the tongue is superior at the 12 o'clock position. It's not going to be there. It's going to fall downwards towards the 6 o'clock. So the next page, we're also looking at some images on the left-hand side. You'll see this little small yellow arrow, and that arrow is pointing down towards the airway. It's just to show you that, the trachea is actually anterior, and then you have the esophagus posterior. And we're looking for that little tip, that little cartilaginous tip of the epiglottis, because that's telling us where the airway is. If you look at the image on the right, at the 6 o'clock position, you see the epiglottis. That is That is the moneymaker. That's where you want to place your laryngoscope blade, because just behind that is going to be the vocal cords, and that's really our target. So if you'll look at this next image, I kind of highlighted with this blue dotted arrow coming from the right. It also shows that the provider knows this trachea is going to lie posterior. And at the 6 o'clock position, at this oral airways clock, the target point for the ET tube, again, as you can see, just under the epiglottis. Really good images. So next, on the next slide, we want to talk about why it's important to identify the vocal cords. So since the visualization of the ET tube passes actually through the vocal cords, it provides you immediate proof that the plastic ET tube has pushed through that particular airway. So that's one of the things we want to talk about, is visualizing what it looks like on the intubation and using laryngoscope. So the right hand side, if you look right here, you see the vocal cords. It looks sort of like a curtain, but it is midline. And you'll see in the lab, if you come, these are really kind of white and cartilaginous. At the 6 o'clock position, these are called arytenoid cartilages, and just superior to that is where you're going to see the vocal cords. Excuse me. So the indications are going to be section 3. This is going to be objective 2. They are what you suspect they are going to be. So what we're going to look at is uncertainty. Uncertainty, critical action items. So one is, if you are uncertain of the patency of that airway, then you need to start considering intubation immediately. Number 2, the patient's respiratory drive and their work of breathing, how much energy they're using. You've heard this term, work of breathing, also is an indicator. This is nasal sniffing. You're going to see there a little stridor, maybe even in their neck. You're going to see all these accessory muscles. These are signs of lots of energy used to ventilate and oxygenate. Another sign you want to intubate. And then obviously oxygenation. We're going to talk about SATs in a minute, but you know, hundreds of people come through the lab, and I always ask them, hey, what's a low SAT to you? And I hear, well, less than 94, less than 90. I get worried when it's 92. We'll talk about what those numbers look like, and you can correlate them actually with an ABG, and hopefully that will help you as well too. So the other indications are time. So in my experience, I've had a lot of people say, don't intubate him, he's going to be on the ventilator, let's try some other things. Or you hear just the opposite of that, and it's, we need to intubate them now. So time is very, very important, and there's some critical elements that I want to talk about. So one is, time is of the essence. Don't wait. Don't waste time contemplating whether they need to be intubated or not. If you were thinking, man, I think this guy might need to be intubated, then you need to start getting the equipment out and getting ready. If you even suspect that thought enters your mind, you need to start considering immediately. Next, early intubation. So there's a lot of conversation about this, but I will tell you what the experts say, and this is it. Early intubation prevents a chaotic atmosphere, a quote, crashing airway nightmare. Everyone has experienced that, either as a provider or as a nurse or some healthcare setting. You don't want to have a crashing environment. And next, it also provides definitive controlled, and it also gives you a higher success rate of having a successful intubation. So time is very, very important. Early intubation is what we're going to suggest for you. Next, other indications also include altered mental status. Everybody says GCS less than 8, intubate. That might be, I can't find that in a textbook. Maybe that's what we all say. But I certainly want you to consider that as well too. So a head injury. Head injury where you want to control hypercapnic situations. Remember, we want to keep their CO2 low, carbon dioxide. Do you guys remember why we do that? I hope you do. The reason we do that is because, remember, hypercapnic or hypercarbic environments cause vasodilation of the vessels. And if someone has a head injury, obviously that would bring more blood supply, and then these patients are going to be at high risk for